I am Director of Menopausal Health, the only program in Suffolk County, and I'm also Director of the Osteoporosis Program. Next slide. Our topic today is a topic that we see quite frequently in women, and that topic is abnormal uterine bleeding. Abnormal uterine bleeding occurs in the reproductive age from 14 to 50, age 14 to 50, in about 30% of people. And we also see abnormal uterine bleeding in women who are menopausal. That is, a woman whose average age is around 51 who has not menstruated for a year. Next slide. Now, the definition of a normal period would be a period that comes every 21 to 35 days. It lasts less than 7 days, and it usually is less than 80 milliliters. Most of you don't understand what that is. What I mean is you maybe would use 3 or 4 tampons a day, no more than that. An abnormal period is a period that comes less than 21 days. It lasts more than 7 days. And what's most important is your perception that's a heavy period and it's abnormal when it affects the quality of your life. In menopause, you should have no bleeding. Next slide. Now, what are the causes of abnormal uterine bleeding? In the reproductive years, from 14 to 50, the major causes would be a polyp on the neck of your womb or inside your womb, a fibroid tumor, adenomyosis, which is endometriosis of your muscle of your womb, lacerations, and rarely malignancy in the reproductive year. By that I mean endometrial cancer. Next slide. This slide would just show lacerations of the vulva, the vagina, and cervix. Next slide. This is what we see if you have a polyp that's coming out of the neck of your womb. When he put that metal instrument in the speculum, the instrument that we use when we do a pap test, we may see this little growth, and this can cause abnormal bleeding. Next slide. Polyps inside your uterus can cause abnormal bleeding. Next slide. And fibroid tumors can cause abnormal bleeding. The worst kind of the fibroid tumors would be the one in the middle of this picture that bumps the lining of your uterus. This causes recurrent abnormal bleeding, and it's very difficult to take care of with medical therapy. Next slide. But there are other causes of abnormal uterine bleeding in the reproductive years. A major one are ovulatory problems in which you don't ovulate. You only make estrogen, and the estrogen builds up the lining of the uterus, and eventually you start bleeding. And coagulation disorders. 20% of young people who have abnormal bleeding have a coagulation problem that we call von Willebrand's disease. Both of these are non-structural. Next slide. The causes of abnormal uterine bleeding in menopause, and we have it in big letters, is cancer. Any woman who is menopausal, who has vaginal bleeding, is cancer unless we rule out any other cause. But also polyps can cause bleeding in menopause, and fibroids can cause bleeding in menopause. Next slide. Next slide. Now, when we look at the various ages from 13, 14 to age 20, the major cause of abnormal bleeding would be anovulation. This young person didn't ovulate. Second would be clotting problems, von Willebrand's disease, and third would be a pregnancy. From 20 to 40, abnormal uterine bleeding can be pregnancy, polyps, fibroids, or anovulation, that's hormonal. And in menopause, it can be hormonal, polyps, fibroids, and cancer. Next slide. Now, how do we make the diagnosis? When you come to our practice or when you go to your gynecological office, your gynecologist should take a medical history. We want to know how your period history is. How frequently do you get it? What's the interval? How many days did it last? And do you think it's a heavy period? We need to know that. Secondly, we need to know what medical conditions you have. Do you have thyroid disease, liver disease, kidney disease? Do you have polycystic ovarian syndrome? Do you have a coagulation disorder? We also look at your family history. Does your mom or dad or sister or brother have a coagulation problem? We look at what medications you're taking. Are you on birth control pills? Are you on hormone therapy? Are you on aspirin? Are you on Motrin or Advil? Are you on any anticoagulants? Are you taking any supplements that can cause bleeding, such as ginseng or ginkgo? Then we do a physical exam. What we look for, looking at your body, are you pale, which could mean that you have anemia? Do you have any bruising? We check your thyroid to see if you have a goiter. We look to see if you're obese because you may have the polycystic ovarian syndrome, which causes abnormal bleeding, and we look for body hair. Then we press on your abdomen and over your symphysis pubis on your hairline. If you have fibroids, sometimes we can feel a mass in your middle, right over your hairline. Next slide. Then we inspect your vulva. We look to see in your anal area, are you bleeding from any hemorrhoids? We then look at your urethra, and we may do a cath urine or have you pass some urine before we examine you, and we look for blood. Then we inspect your vagina to see if you have any lacerations. Next slide. Because these would be a reason why you're bleeding. Next slide. Then we put a speculum in, the instrument that we use to take a pap test, and if we see a polyp, then we know that can be the cause of your bleeding. Next slide. Then we do a bimanual examination with our fingers, with a glove, to see if your uterus is enlarged and irregular, and then we can make the diagnosis that you have a fibroid uterus. Then we order some lab tests on you. We want to know if you're bleeding, what your CBC is. I need to know if you're anemic. We may do a coagulation workup on you and check you for von Willebrand's disease. We absolutely would check your thyroid, and we would do a pregnancy test. And in the office, next slide, what we would do before the lab test is we would do a sonogram on you, a transvaginal. We may do a sonohystogram, and I'll explain to you what that is. We may do a hysteroscopy in the office or in the hospital, and we always take a biopsy or do a D&C to check the lining of your uterus. Next slide. Those of you who come to my practice, Julie, our technologist, we do a transvaginal sonogram. That's the instrument in the vagina that checks the size and shape of the uterus and checks the lining of the uterus. Next slide. What we may do, what I may do, is put a sterile instrument inside your uterine cavity. It has a little balloon on it, and we inject into this instrument sterile, normal saline, and we take a picture that we can see the outline of the endometrial cavity. Next slide. And here's a lady in the reproductive stage of her life who we're doing a sonohystogram on it, and the black is that water, the normal saline salt water that we injected, and up on the top, you can see a little bump. That's an endometrial polyp. That's the cause of this lady's bleeding. So this lady would be brought into the hospital, and what we would do, next slide, is while she was asleep, we'd put this instrument, this black tube, it's called a hysteroscope, and we would, under direct vision, we would remove that polyp. Next slide. If you had fibroid tumors that we saw on your ultrasound, next slide, and fibroid tumors in the reproductive stage of life are quite common. All you ladies out there, 80% of you will develop fibroids in your lifetime, and your risk factors are, especially if you have an African ancestry, if you have a family history, if you have a late menopause, you're at risk for fibroids. But not all fibroids have symptoms. The ones that have symptoms cause uterine bleeding because the cavity is bigger. And this uterine bleeding can cause anemia. It can cause bulk syndrome. What symptoms? By that I mean they're so big they press on your bladder and can cause urinary frequency, urgency, or the urine or loss of urine when you cough and sneeze, or they can press on your rectum and cause constipation. And for the younger patients, they can cause infertility. Next slide. Now, how do we treat fibroids? Well, it depends whether you want more babies or not. If you want more children, if you want more babies, and you have large fibroids, we may do a myomectomy. We just remove the fibroid. If you finish with childbearing, your gynecologist might offer you a hysterectomy, or he might offer you a uterine embolization. What that means is we send you to a radiologist, they catheterize a leg artery, and under direct vision, under fluoroscopy, they go to your urinary artery and put an artificial clot there, taking away the blood supply to the fibroid. But we could also, if you don't have the fibroid that bumps the lining of your uterus, what we can try to use are birth control pills. We can try to use Motrin or Advil to control your bleeding, or we can put in a progestin, that's a progesterone IUD. Why? Because that can change the lining of the uterus so you stop bleeding. And we now have new drugs for those women who have persistent bleeding and they don't want the uterus to come out. We have drugs that you can take that put you into a premature menopause that stops all bleeding, because what causes the uterus, the fibroids to grow is estrogen, and that stops their growth. Or we can give you something that stops progesterone by mouth, and that also shrinks your fibroids. Next slide. Now, what do we do if we did this extensive workup with sonograms and hysterosonograms, and we didn't find anything, we did a biopsy on you, and the biopsy didn't show anything? That's called an ovulatory bleeding, or bleeding from an abnormality in your production of hormones in the reproductive stage of your life. And that's treated usually with combined oral contraceptives, birth control pills, or a progestin IUD, or you can even use Motrin or Advil with your period. If you're finished with childbearing, what can be done is an endometrial ablation with freezing or thermal. We can burn or freeze the lining of your uterus so you don't get any more periods. Next slide. What about if you're a young person and your workup showed that you had a coagulation disorder, and the one I want to talk about, and this coagulation disorder causes 20% of all abnormal bleeding in women in the menopausal stage of life, and it's called von Willebrand's disease. Next slide. Von Willebrand's disease is the most common bleeding disorder, especially in young women. You're lacking something in your blood, the von Willebrand factor and factor VIII, that causes your blood to clot. And the symptoms in a young lady would be heavy periods, they're anemic, family history of heavy periods, and a history of frequent nosebleeds. When you brush your teeth, you bleed. When a tooth is pulled, you bleed. After surgery, you bleed. And after a vaginal delivery or cesarean, you bleed. How we treat that is with a combined birth control pill, or that's a pill with estrogen and progesterone, or a pill with just progesterone, or a progestin IUD. Next slide. Now, what about postmenopausal bleeding? I had told you that I'm director of menopausal health, the only program in Suffolk County, probably the only program in Long Island. And postmenopausal bleeding in 90% of women who have cancer of the lining of the uterus is the first sign, the first symptom. If you have postmenopausal bleeding, 4.5% to 5% of you have cancer of the endometrium. And if you have postmenopausal bleeding, it's cancer unless we prove it isn't endometrial cancer. Next slide. Now, what are the risk factors? Look at the risk factors in big letters: obesity, diabetes, and hypertension. Other risk factors: an early first period, a late menopause. Next slide. Postmenopausal bleeding, we need to rule out, we menopausal doctors, your gynecologist must rule out it's coming from the uterus, and it's not coming from your bladder. It's not coming from your rectum. It's not coming from your vagina, and it's not coming from your cervix. I have to rule out it's coming from the uterus. Next slide. Now, how do we do that? First, we inspect the outside of your vagina. We look to see if you have hemorrhoids. I made catheterized up on top. You see a round thing with a tube in it. We make that's your bladder. We put a catheter in your urethra and we draw urine and we look for gross urine. We look for gross blood and we'll send it to the lab for microscopic hematuria. And what can cause bleeding in menopausal ladies from the lack of estrogen in the vagina are these little ulcers that you may have in your vagina that you may bleed from. And I'm able to see with this speculum in, the instrument that we take a pap test with, if blood is coming out of the neck of your womb. And then I can say with assurance it's coming from your uterus. Next slide. So what do we do if we ruled out it's not coming from your bladder, it's not coming from your rectum, and it's not coming from your vagina? We do Julie, my tech, we do a transvaginal ultrasound. And what we're looking for in this case is how thin or how thick is the lining of your uterus? How thin or thick is it? Next slide. This on the left is a slide in a woman in the reproductive stage of your life. The uterus is opened up like a clam, and the dark pink is the lining. Look how tiny on the right a menopausal uterus is. The lining is pencil thin. Next slide. So when we do a transvaginal ultrasound on a menopausal woman that we think the bleeding is coming from the uterus, if the lining is 4 millimeters, Julie, the tech, will measure it, or less, the incidence of cancer is like 1 in 1,000. That's how rare it is. But if the bleeding persists, even though it's that thin, we would do a biopsy or D&C on you. If the lining is more than 4 millimeters, we must rule out cancer. Next slide. So we would do that hysterosonogram. I put the instrument inside your uterus. We squirt in normal salt water. We take a picture. Next slide. And if we see a polyp, we remove it. If we see a polyp, we remove it. Next slide. Now, the problem with polyps in menopause is that 10 to 15% of you without bleeding have polyps inside your uterus. The problem with polyps in menopause, if you're bleeding, have postmenopausal bleeding from your uterus, and you have a polyp, you stand a 12% chance of having cancer in the lining of your uterus. Next slide. If you're menopausal and have polyps and no bleeding, and you're obese, and by that I mean your BMI is 30 or 40 or more, and you can figure out what your BMI is. Your BMI is how you calculate it. All you have to do is Google BMI, and you put your weight and your height in it, and it gives you a number, your body mass index. And obese would be a BMI of 30 or more. Morbidly obese would be a BMI of 40 or more. Or you have diabetes, and when Julie measures your polyp across, if it's more than 1 centimeter, we recommend we remove the polyp because it increases your risk of cancer of the lining of the uterus. Next slide. How about endometrial cancer? Endometrial cancer is the #1 gynecological cancer. It's more frequent than ovarian cancer. It's more frequent than cervical cancer. Next slide. There are 64,000 cases a year with 10,000 deaths. It's the disease of menopause. We rarely see it in young people. It's usually the average age is in the 60s. And the risk factors, again, are obesity, diabetes, hypertension. Next slide. How we diagnose this? We do a transvaginal ultrasound. Next slide. We could do a sonohysterogram. Next slide. And we do a hysteroscopy and biopsy. And if you have endometrial cancer, the therapy is a complete hysterectomy. We remove your tubes and ovaries, and the surgeon that should be doing this is a GYN cancer surgeon. This is handled by a GYN cancer surgeon, and they sample your pelvic lymph nodes and the major lymph nodes around your major vessels. You have to remember that if you're in the reproductive stage of your life, in your like late 40s or early 50s, and you're not menopausal, and your BMI is 40 or more, that means that you have morbid obesity. Your lifetime risk for endometrial cancer is 3%, which is very high. And if that's you, what we recommend that we can do something simple. We can put in a progestin IUD to prevent it. The takeaway points from this study is, or this talk I just gave, abnormal uterine bleeding is not normal. Secondly, obesity is a major risk factor for endometrial cancer for you developing over your lifetime. You must all exercise 1 hour every day and eat a healthy diet. And that's the end of my lecture. Does anyone have any questions? Are there any call-in questions? Teresa?
So there are no questions currently in the chat. Does anybody have any questions that they would like to ask Dr. Bonura? You can just unmute your mic and go ahead.
Yes, can't certain medications cause uterine bleeding?
You have to say, I couldn't quite.
Like I'm doing this. Okay.
What? What did she say? I couldn't understand.
Maria was asking a question about medications. Can you repeat it, Maria?
Yes, can medications cause uterine bleeding?
Yeah, of course. In the reproductive age, if you're on aspirin, if you're on non-steroidal anti-inflammatories like Motrin or Advil, can cause bleeding, absolutely.
What about if you're menopausal?
In menopausal, what things can cause bleeding? If you take too much hormonal therapy, we can cause bleeding.
Yes. Mhm.
Absolutely.
Okay.
Hormonal therapy can cause bleeding. If you're on an anticoagulant and you're menopausal, you can have uterine bleeding.
Thank you.
Are you on any medications?
I'm just on Vagifem right now.
Yeah, if you look at, I did a video, it's on my webpage. Go to frankbonuramd.com, click the blog on genitourinary syndrome and menopause. What we use, we menopausal physicians, we use a very low dose of vaginal estrogen, and it's usually not absorbed into the uterine cavity. And many of them are so safe, we use it in women who have breast cancer after we speak to their oncologist.
Yeah.
And it should not cause uterine bleeding. Are you using a vaginal tablet or are you using a cream?
The tablet.
Yeah, the tablet is one of the lowest doses. It only gives 10 micrograms of estrogen. So it should not cause any uterine bleeding. If you develop uterine bleeding, then what should happen is that your doctor should do a transvaginal ultrasound on you and see the lining of your uterus. And if it persists, you should stop the Vagifem. And if you continue to bleed, the doctor should do a D&C and hysteroscopy.
Thank you.
Any other questions? Now, I'm in a quandary. I need to know, and I'm going to give you my email. It's fbmdobgyn@aol.com. I normally don't do this. I need suggestions for future topics. What are you folks interested in? Remember, in Long Island, there are 750,000 women approaching the menopause or who are menopausal. In the United States, there are around 64 million women who are menopausal. So if you have any suggestions, I would appreciate it. I think that's,
Please
I hope
repeat
you
that.
all had a nice lunch.
Maria, did you have another comment?
Yeah, if the doctor could please repeat his email address.
FB, my initials, Frank Bonura, MD, OBGYN@AOL.com.
Thank you.
Okay, ladies, have a nice day.
Okay, the email address is in the chat for anyone who'd like it. Thank you for joining us again. Have a great day, everyone.
Thank you.
Bye.
Thank you.